So I'll go ahead and officially introduce you now that you're here. So ladies and gentlemen, this is a lady that many of you know. I don't think we need to introduce her to really anybody in this room. She's well known in this community. She's been blazing trails for those of us who are work and live in this community for many years. She's unafraid to speak up and speak out for the things that she believes are important to her constituents. She has been an advocate for so many things, and in particular, since we're talking today about health, I want to just say that she's been an advocate for HIV, education and awareness and prevention, and she also has some personal experiences about being an advocate. She actually has a passion, I think I would have to say, for the importance of advocacy, and we've had some exchange some stories. We were honored that she was willing to be able to sort of bless our book when we put this book out a couple of years ago. But this is really a woman that speaks up and speaks out for our community. She is our 13th Congressional District Representative, and without further ado, I would like to turn the program over to Barbara Lee.
It is. It's winter time. So, first of all, good afternoon, and thank you, Dr. Hick, very much for inviting me to be with you today. I want to thank all of you and all of you for really, as we say, staying woke, because I still have the wokest congressional district in the country on each and every issue that we have to deal with, both locally and nationally. So thanks so much for this. Also, just as it relates to where I just left, I was at Merritt College introducing one of our new colleagues, Congresswoman Lauren Underwood. She was the Mills commencement speaker. And she is a nurse by profession. She's from Illinois. She beat 6 white guys in the primary. She's the youngest African-American woman ever elected to Congress. She's 32 years old. And her district is 86% white. So you know the sister is tough. She is really an unbelievable woman, member of Congress, and she actually now has helped us put together the Black Mothers Maternal Health Caucus. And so you know the numbers in terms of infant mortality and Black women mortality as it relates to childbirth, maternal mortality, and so she's really organizing us around those issues. And so we were able this year, just last week, to get some money put into the budget through what we're doing through the appropriation process to address this in a big way. So we're on sort of a roll right now as it relates to healthcare. In many ways, we're playing offense and defense. A couple of things I just want to mention just in general before we just kind of talk about patient advocacy and the importance of that. But I serve on the Appropriations Committee, the subcommittee on Labor, Health, and Human Services. This is the subcommittee that funds all of our agencies, Department of Labor, Department of Health, of course NIH, CDC. It funds every domestic agency except for HUD and Treasury. And this is the first year we were able to plus up the budget by almost $12 billion. And excuse me, we were able to plus up NIH by I think $4 or $5 billion. And the way this works is, of course, 45 in the White House, they submit their budget. And then we look at that and we say this is dead on arrival. And then we start negotiating what we want in our budget. And so because let's see, I'm on that subcommittee, and Congresswoman, this is her first year, Bonnie Watson-Coleman, in terms of African Americans. And so of course we go to the Congressional Black Caucus and we talk about our priorities as CBC members. And I want you to know that we worked really hard this year with all of our appropriators, and we were able to not only beat back Donald Trump's cuts. I mean, he wanted to eliminate the Office of Minority Health. He wanted to eliminate Minority AIDS program. He wanted to eliminate our health disparities, our REACH program, every program that we fought for to begin to close racial and ethnic disparities, he was eliminating. HIV, everything. But not only did we beat back the elimination of these programs, we plussed them up by billions of dollars. And so I'm very proud of the work that we did.
Great.
On that, we have to stay woke as it goes through the process. But even now with this, you heard him talk about this new HIV AIDS domestic agenda, which sounded, you know, he said this in his State of the Union, began to stamp HIV and AIDS off the face of this country as well as abroad. But what he did was, we looked at the budget, he took money from PEPFAR and our global initiative and other accounts to put it into this account. So that's how they operate. So as an appropriator, I got ahead of this, and I called CDC because CDC is going to implement it. They've identified 48 counties around the country. Of course, Alameda County is one of them. And the non-Trump appointees are the ones who are responsible for implementing this new program around HIV and AIDS. And so we were able to, through our negotiations, through the appropriations process, not only keep them from robbing Peter to pay Paul, but we found billions of dollars of new money, okay? And so we got that in, and I wrote in language into the bill. And I'm telling you all this because a lot of times it doesn't get down to, you know, we do all this work, get all this money, and there it's sent. So I got the language in that said they had to look at the groups on the ground, the groups that are most affected by the HIV/AIDS epidemic, the healthcare workers, the physicians, the nonprofits, the advocacy groups, and prioritize the funding for these organizations. And so once this bill is done, if the Senate doesn't mess with us and if it doesn't get messed up in conference, we should position ourselves in Alameda County to be ready to beat the drum and write these proposals and get some of that money in. Okay, because it's going to be quite significant, and it's targeted, and it's going to be from the ground up. So there's a lot going on in healthcare in terms of not only trying to preserve the Affordable Care Act, but to expand it, to expand Medicaid, to make sure that and I've been working a lot on lupus, on COPD, of course my mother had COPD, on multiple sclerosis, my sister has multiple sclerosis, a lot of the diseases, breast cancer, prostate cancer, sickle cell, there should be a cure in a couple of years. The clinical trials, you know, are doing fairly well. So I'm going to have a town meeting here with NIH on where we are on sickle cell and trying to encourage more people to really focus and get into these clinical trials. We're trying to get the funding because it's going to cost a lot of money once they're done. But there will be a cure pretty soon to sickle cell. So I've been working hard on that through the appropriations process. So all of the issues that we know here in the Black community especially that affect us disproportionately, we have NIH, you know, prioritizing these diseases in terms of prevention, care, research, and treatment. Finally, just on patient advocacy, yeah, you know, many of you knew my mother, and many of you know my sister. She lives in Las Vegas. And I was my mother's caregiver for many, many years. She passed away 4 years ago at 90. But in her last 4 or 5 years of life, we were in the emergency room all the time, every 6 or 8 months, because of her COPD and infections and pneumonia and what have you. And it was during this period that I realized, and with my sister also, that if you don't have somebody at the key points in the healthcare system to be an advocate, stuff for whatever reason just falls through the crack. It just falls through the crack. My sister, for example, she was at the hospital and she had an MS flare-up, and I was there with her trying to help out, and they were getting ready to prescribe, I think it was prednisone or something, for her. And I said, well, wait a minute, did you check her records? It seems like either she's allergic to or can't take that. And so the person in the emergency room said, oh, that's a good idea. Give me her doctor's number. give me her doctor's number, okay? So I share that one experience, but I've had, like many of you, you probably have had thousands of experiences where that advocate has to be there. It doesn't need to be an employee of, you know, the emergency room necessarily, because social workers and doctors and nurses and nursing assistants, PAs, they're busy doing what needs to be done to save people's lives. You need a specific, dedicated person and persons as patient advocates to help patients and families work through these systems so that the patient gets the type of care that is necessary so that mistakes aren't made, but to free up the health providers to do their job. And I'm telling you, Lord knows, I sat in emergency rooms with my mother and my sister like sometimes 8, 10, 12 hours every night, and I'm checking machines, I'm checking this, I'm running out saying, oh, did you know that? And does this medicine mess with that, interact with that medication? Oh, yeah. You know what I mean? And so I had to do all of that for many, many years. And so we had talked about setting up a curriculum with a specific certificate through this college, right? One day. One day, 8 years ago, one day, to have a specific certificated program that provides the curriculum, the experience, the necessary internships, and at the end of the day, certify individuals to be those patient advocates, a specific position. So I'm so glad that this book came out, and maybe this, now we have a new administration here, maybe Merritt will once again go back to the drawing board and consider our proposal, because it's badly needed. And with this healthcare system, it's such a mess. You know, we need more patient advocates. With the Affordable Care Act now, they're cutting back with the, you know, people who are supposed to go out and help be the people who bring people in and recruit people. The advertising budget is cut. And so, you know, it's a mess. So we need that, and thank you very much. So I would love to answer any questions, but thank you, Glenda. So we got to make sure this administration understands it's been 8 years.
We look forward to that.
Okay, so you train people, you get them certified, how do they get paid? Are they hospital employees? Are they patient employees? Are they from the insurance system? Where do they?
I don't know yet. We really haven't gotten that far.
Okay.
I mean, I would want Medicaid and Medi-Cal to reimburse. I would want that. And insurance, but I don't know. We haven't figured that out.
There are some models already that there are patient advocates with some of your insurance companies. They don't tell you about it. I actually have a colleague that had a situation. She actually had a mastectomy, and then wanted to decide later to go back and have reconstructive surgery, and then somebody mentioned to her that her insurance had an advocate, and she was having trouble getting to someone for that appointment. She connected, the insurance company said, oh yeah, we have advocates, but it's never advertised or never listed anywhere. And once she locked into that advocate walked her through to all of her appointments, followed up, and really made it a smooth transition. So I don't know which ones have it, but some insurance companies are already paying for it.
The other thing that I've been alarmed about in the last few days are these bills that are going through state legislators about abortions and how we fight that. And I also am having a problem understanding why going so radical will push them closer to the court. It seems to me such a radical bill would have more trouble getting through the courts than something a little bit more civilized. Am I?
Well, there is a war on women's health. I mean, it's a war on women, a war on women's health, and it's really very dangerous, very scary. Many of you remember before Roe versus Wade. I certainly do. Back alley abortions, I certainly do. And so we're in a war right now with these people. What they want to do is they have enough cases around the country. Missouri's coming, North Carolina's coming. They're building this, okay? But I don't think they're going to win in federal court. But by then, there are going to be so many women who have died, and and who have lost their rights that we'll have to fight even twice as hard and figure out we need to. And we're trying to get a federal law passed, because right now it's a Supreme Court decision, Roe versus Wade. We haven't really passed a federal law saying a woman has a right to make her own healthcare decisions. And so what they're doing now, I'm going down to Alabama in a couple of weeks, is just outrageous. And you know that it's negatively impacting disproportionately black women in a lot of these states. And so, again, on the Appropriations Committee, this is sort of where I serve on that labor subcommittee and health subcommittee, the epicenter of what they're trying to do. Just this week, they tried, and fortunately we have the numbers now thanks to the election, to take away family planning again, to deny women access to contraceptives again, to roll back comprehensive sex education and put in the abstinence only again, to say, and I won this one big time, which Trump came up with 3 weeks ago, to say that healthcare providers, a doctor, a nurse, ambulance driver, receptionist, whomever that provides healthcare, can say no to the health service if it's based on their religious beliefs. Anybody. And so I did an amendment to say we're not going to fund, no funds can be used to implement this rule. We won that. And so hopefully that'll hold. We won that. I could not believe it. I mean, so they're hitting us in all. If an ambulance driver decided he did not want to take a woman to the hospital because she was having a miscarriage, he or she wouldn't have to do that under Trump's rule. So this is a concerted effort by the right wing that started before Donald Trump, but he's their flag waver, and he's carrying their ball, and we're in an extremely dangerous period, not only in terms of health care for women, but for African Americans, for people of color, for low-income people. This 45 in the White House wants this country to become a dictatorship. I mean, he's on the road to do that. So we have to be really clear on what's going on. So we have to fight hard, go to rallies, do the social media, just organize. We have to organize around this. But I think we'll be okay at the Supreme Court, but we don't know yet, because so many states may have, gotten their cases together,
Will the Democrats begin to have more advertising regarding what you're doing instead of the Republicans taking over television talking about what they're doing?
Yeah, but listen, let me tell you, we're doing a lot. We have passed so much. It's like, some of it will be dead on arrival in the Senate unless the public organizes, and that's why we need the media to make sure that the public weighs in the Senate side. We did the Equality Act yesterday. We did the Violence Against Women Act. We passed a heck of a lot. The media, like tomorrow I'm going to do, whatever her name is, Alex DeWitt on MSNBC. And so we're negotiating, but they don't want to talk about anything but what they want to talk about. And so this corporate media is what it is. And so we try to do more social media, because right now they're not going to put forth any kind of a message or program or talk show or media that covers what Democrats are doing. That's just not the way they're doing it. And so we're fighting to, like, I try to pivot into something. Like tomorrow I'm gonna try to pivot into something else to talk, but I don't know, they'll jam you and bring you back. So you have to really, but that's them, it's not us. We're trying, so we're using alternative ways to get our messages out.
Barbara, are there some ways that we can get some information from your wonderful team? Let me applaud your team that came early, stayed late. You guys are wonderful, fabulous. Liz, Tatiana, Jane.
They work 24/7.
They are outstanding and wonderful. Thank you so much. But I'm sure they might be able to provide some of us with some of this information that we might be able to begin to share individually on your own Facebook pages. Because as she said, it's just like if there's something, it's like the media's not here today to hear about this, but the media is going to be somewhere on East 14th Street telling you about something negative going on. So that's the way it is. So we're going to have to be the agents to be able to put this on our own Facebook pages and send that message. So maybe we might be able to, we do have your email addresses with your permission. We can probably get some talking points from Liz and be able to share that with you so you can be able to spread that information.
And also the appropriations, because we need to get the word out. I do as much as I can through social media, through email, through letters about what we're doing in appropriations, but we need to be ahead of the curve so you can know because if there are any individuals, organizations, doctors, lawyers, healthcare providers who want to begin to look at submitting proposals for this funding, now's the time to start organizing around that, because I hate to see the money go down without my district getting any of it, you know? So listen, Bob, it's good to see you in another context. You know, Bob is the chair of my finance committee, and Glenda is right there. I have two finance chairs, really. So thank you all very much. It's really, really good to see you, and Michael and Brenda. You guys are really doing an awesome job on the front lines, taking care of people, my constituents, each and every day.
You're the Congresswoman ahead.
So we are honored today to have a celebrity in our midst. We have Dr. Michael LeNoir, who is a practicing physician in this community, has been here for many years. He is an allergist and a pediatrician. If you have been sick in this community and you have been a child in the last 20 years, he has taken care of you at some point in time. 40 years, okay, I didn't want to put that on you. He's too young looking for that. But he is, not only is he a wonderful physician, but he's also a community advocate. He's also a radio and television talk show host. And has been doing that for many years, and we are just so honored. When we first released the book, Michael was kind enough to put us on his radio program, and he's wonderful. One of his other expert areas is communications. So we're honored today to have him to be our moderator. Dr. Michael LeNoir.
I'm always excited about talking about advocacy because it is so critically important in keeping you healthy and taking care of you when you're sick. Start out with a couple of statistics. I did a piece yesterday on maternal mortality in this country. And if you look at maternal mortality, the United States is the only civilized country where maternal mortality has gone up. 3/4 of the people, women that die giving birth, are African Americans. And it doesn't matter, and so many other things don't matter, what your income is, what your titles are, who you are in the community. That for almost every single health statistic, African Americans are sick out more often, in the emergency more often, and die more often. And so 20 years ago, we founded the African American Wellness Project because of the rage that I had sitting in the doctor's lounge listening to talk about African Americans, and realizing that if you don't have an advocate in this process, you're not going to get the kind of health care you need. And so consequently, Dr. Spriggs and Dr. Harris, Newell Harris, wrote the book I wanted to write. It is one of the very best books on patient advocacy I have ever seen, and I've looked at a number of these books. Let me give you just a couple of anecdotes. If any of you is sick and you go to the hospital and you're African American, you're not going to get the same quality of care. They don't think you need to know the information. They may come or they may not on a regular basis. But if you call me and I call them and say, look, my cousin is over there, and I do this about once or twice a week, and to Georgia, Mississippi, Chicago, New York, my cousin's in the hospital there, I'm Dr. LeNoir, and I need to know what's happening, your quality of health will change immediately. They'll start paying attention to you, they'll start doing things for you, and that is unacceptable. I can give you one anecdote and then we'll get into our panel. The anecdote, I was in the hospital making rounds and I had to miss a baby, so I went back out to Vegas. And I saw a Superior Court judge's wife crying in the lobby. And she was crying in the lobby because her husband had some, I don't want to get into too much detail, but had a major problem in Europe. They flew back. He didn't get his doctor. He went to the emergency room, was admitted. And the specialist that needed to see him had not seen him for 12 hours. Wow. And so she was upset, she didn't know what to do. So of course, I make a habit of, as a pediatrician and seeing babies, of having at least 2 tantrums a year over insignificant things. Because I don't want them to think that if something happens to my patients, I'm going to accept it. So I make up something, and I get the nursing supervisor, get everybody engaged, because I'm upset about something. And I said, oh, it's time to do this again, so I just do it about every 6 months. So when I go on the ward, I don't hug the nurse, I don't say hello, and I mean, I'm not interested in sharing my family stuff. But I know that they will pay attention to the things that I want done, simply because they know they don't want that kind of confrontation. So I went upstairs, had one of my real tantrums then. And then I went down to Alta Bates, to the patient information. I said, you've got a judge upstairs who is about to leave this hospital because of poor care. And of course, they moved him into another room. But that should not happen. That should not happen. That should not have to happen. But it happens all the time. It happens in the doctor's offices. It happens in the emergency room. It happens in the hospital. And so when you talk about patient advocacy, you have to build your own health system. We are the only projects in the Bay Area that talk directly to people, black or white, about their own health. They'll let you call and ask questions and all that. And we try to do every week at least 1 or 2 pieces that gives you the information so that you can create the health system for you and your family. And I'm so proud of Dr. Spriggs and Dr. Newell Harris about this book because it gives you all the information that you need. And so consequently, it's good to have the opportunity to talk to them about this book, why they wrote the book, and what their experience has been, and some of the tools that you need to build your own health system. The most important decision you have to make is who's going to be your primary care provider. And if you don't have a good relationship with that person or that office, then you're doomed from the beginning. So first I'd like to start with Dr. Spriggs, asking why did you, what is it about the advocacy issue that made you want to collaborate with Dr. Newell to write this book?
Well, I have a long history of advocacy for women because my specialty is rheumatology, and most of the patients that I see are females, teenagers as well as adults in my training program. And when you are a rheumatologist, you see all systems are involved. So you sort of become the spoke in the wheel for the management of that disease and other diseases also like rheumatoid arthritis. So we felt that, I felt, and so did Glenda, that we were being called, as you are, you know, at least once or twice a week. I have 3 cases going on now that I'm doing advocacy for. And we said, well, why not just write the book and teach everybody how to do this? So we started getting seminars before we wrote the book all over the East Bay and sometimes in San Francisco, trying to teach them about the importance of advocacy. And then we stepped back. We then wanted to go to the corporations to see if we could pigtail on their wellness programs. They weren't hearing it. The Affordable Care Act was in process at the time. So we said, well, let's just step back and write the book. So that's what we did, to try to teach individuals how to take care of and get the best health care. I feel very personally that patient advocacy is now the new frontier for health care reform.
Dr. Newell, do you have a personal experience in the healthcare system that you can share that pushed you either with a relative or a friend or that pushed you to be interested in this area?
Yes, you know, as a physician, it was sort of a natural to go from taking care of patients to taking care of your family. So initially, sort of being an advocate in the household was not really something that I looked at as an extra job, or because it was just kind of, well, I'm doing this for the day job and now all of a sudden I've got issues at home. But I think the thing that really, I think, clinched it for me was when I took a trip to Africa and returned, and I returned home to my son lying on the sofa with at that point, about 12 or 13 hours of abdominal pain. And of course, I'm packing and unpacking, and I look up and I realize that like 18 hours have gone by and he's still on the sofa with abdominal pain. I've pretty much ignored him because I've been unpacking. And then I looked up and realized it was like 11:30, and I go to take a shower, and I come out of the shower, I put my clothes on, my husband says, "Where are you going?" I said, "We're going to the emergency room." And he said, "Well, didn't you just take him to the emergency room for abdominal pain?" I said, "Yeah, but they didn't take out his appendix the last time, and it's still there, so we're gonna go." And so we went to the emergency room. We sat for probably about 4 hours before we were seen, and ultimately remained in the emergency room for probably about another 8 or 10 hours, at which point the chief of surgery said, "I don't think your son has an appendix, so I'm gonna turn him over to my colleague who will be here in about an hour, and then they'll take care of it." And of which I had to then go and beg the physician to please take my son's appendix out, because even though he wasn't a typical presentation, my training in medical school, even though I'm not a surgeon, was 18 to 24 hours of abdominal pain. You go in on the abdomen to remove the appendix, whether it's normal or not. Long story short is that an appendix was removed. It was a near rupture. They told us that he would be in the hospital for 24 to 48 hours if there were no problems, but instead he was in for 3 or 4 days for intravenous antibiotics. Now, they knew I was a physician, and I don't know what else to tell you. But my concern, and it's been, I must have at least about 5 of those episodes, being at my mother's bedside, being at my son's bedside. I've even had the opportunity to be at my husband's bedside. And I think the thing that just continues to make me be passionate about this is that it seems to still never matter that when they're giving report from nurse to nurse, I'm sure they say bed 24 has a doctor at the bedside. It still doesn't seem to matter. So I continue to be passionate about this because my feeling is, and I think the thing that really drove Brenda and I to write this while we were working our day jobs all day and all night, was that if this is the way that we're going to be treated and our family's going to be treated, then what on earth happens to people that don't have the medical knowledge?
Yeah, I often say to people, and I'm going to talk next about the communications and how important that is, that if African Americans got as upset about health care that's poor quality and inadequate as they do when somebody cuts in front of you in the same room, we wouldn't have this problem. And I can give you a really quick example of a radio program we used to do on KDIA years ago, and the gentleman kept calling and says, I go to Kaiser, I can't breathe. I said, well, he said, well, what should I do? And he called it and said, you go into that lobby and you just act black. I'm not going to take it. I'm not taking this anymore. I'm not getting the care I need. Because the healthcare system does not like confrontation. Doctors don't like it, nurses don't like it. But, and you know, the next week is, Dr. Norwood at UCSF, I've had an operation, and you know, everything happens that way. So communication about communication about how you're organized to enter the healthcare system, communication while you're within that system. How important is that, Dr. Norwood?
Dr. LeNoir, I'm sorry, we just had an interruption, and I want to pause for just this moment because I've just learned that the president of Merritt College has just arrived, and so we're going to need to just pause and allow Dr. Maria Lane Burns to come on in. We are honored to be here on her campus, and so for just a moment, I would like to introduce Dr. Maria Lane Burns, who is the relatively new president of Merritt College. Dr. Maria Lane Burns, please come and greet us.
Excuse me for being late, but we had our African and African American graduation at BB Church on Telegraph, and we had lots of students there. So of course we had to shake hands and go through, and it was all 4 colleges. It was wonderful. 2 of the trustees were there, as one is here. They split up so they can share, and then the College of Alameda is also having an event. So we've got trustees running around, presidents running around. So my apologies, but we are so glad to have you all here to talk about this very important issue. I know from my own personal experience, when I moved to LA for a little while, I was living down there, and my mother had to go into the hospital. And she called me from the hospital one day telling me these things, you know, and you know, number one is your mom, but number 2 is my mom, and I know how she could be high-strung. But I was listening to her and I was thinking, wait a minute. So because I knew her cardiologist, because, you know, I went to the hospital with my mom all the time when she went for her appointments. So I was able to call Dr. Carpenter, and I said, Dr. Carpenter, my mother's saying this, 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 and this. What's happening? You need to take care of her. I said, and please don't make me come all the way up to San Francisco. And knowing my mom and knowing me, he listened because he's like, oh, both of them at one time, no way. But unfortunately, many in our community don't have aggressive moms like I did and children that can help them. So for many, they don't speak English, and that makes it even more difficult. Others, particularly when you get older, you know, you tend to think, well, these are doctors, and they've been training, and they've done all this stuff, and so they know everything. So sometimes, or many times, there needs to be intervention. There needs to be advocacy. And doctors are human beings. They are not God. They don't know everything. And you have to question them. I know they get angry with me when I question about myself. Well, wait a minute, why is this? Or why are you giving me Actos when it's killing lab rats or what, you know, and then they look at you like, how dare you? Look, I don't have an MD, but I got a doctorate, okay? So, but don't take advantage of, but that makes me mad because I have to tell them that. But don't take advantage of my mom or even my girlfriend's mom. And so this type of program that we are delighted to pursue and try to have a certificate and degree here at Merritt College for is definitely needed. I'm sorry, I haven't seen her in a long time. So, and excuse my hat because you know I had the mortarboard on and I'm telling you with the rain.
It's
Anyway.
okay.
So I'm being stylish right now, okay? I'm being stylish, not unprofessional. But I think this is very significantly important, and we're best to have this program than here at Merritt College. And it will be offered in this building, the Barbara Lee Allied Health and Science Building. And so our Vice President of Instruction will be moving forward and working with whomever we need to work with to ensure that we provide the program that our community needs. So that our, you know, once you give them health care benefits and then you don't teach folks how to navigate through it, you're still almost back where you were. So we will be moving forward on that and appreciate you coming here to discuss it with the community and giving Merritt College the opportunity to move forward on this. This is so important. And I just want to welcome you to Merritt College. I hope you learned lots of good things from this event today, but look forward to hearing that we will be offering a certificate and or degree in patient navigation. Thank you so much. Thank you very much.
All right, so we were talking about communication and the importance of communication in the healthcare system. What do you mean by communication, and why is it so critical?
So one of the things that we decided when we were creating this book was the importance of how could you be the best advocate? And we broke this up into 3 areas: communicate, navigate, and advocate. And so it's no surprise, it was by design that the first chapter would be about communicating. Communication is critical. It's the difference between calling the doctor saying my son is sick and wondering why it takes you 3 days to get an appointment versus saying my son has a fever of 103, he's had dry diapers for 24 hours, I can't get him to take in any food. That's gonna get you to the front of the line. Mm-hmm. I'm sick and that's the same for you as an adult. So communicating, telling the doctor the truth. If I put you on blood pressure medication and the blood pressure medication makes you sleepy or groggy and you don't tell me that and you're coming to me and I'm checking your blood pressure and it's continuing to go high, guess what? I'm just going to give you more medication because I think that the medication is not working. So effective communication, and it works both ways. So we have to stop using jargon with our patients. We use so much of that with each other that, you know, you have to really kind of, it's like going to the mechanic when he starts talking about stuff, or when you talk with lawyers. We've got to talk so that you understand it, and as Dr. Burns pointed out, make it plain. If we're starting to talk in crazy stuff that doesn't make any sense, just break it down. You're intelligent people, and you know we are required to be able to talk so that you will be able to understand what's going on. So communication is critical, but it's definitely a two-way street.
Dr. Spriggs, what do you think that people who are ordinarily pretty aggressive in their professional lives, personal lives, are so don't communicate well in the healthcare system?
I think people are somewhat daunted by the healthcare system. I think Dr. Burns alluded to this. You think that the doctor is the end-all, be-all, and that's not true because they are still learning. It's called the practice of medicine, and there's an art to it also. So I think they are somewhat intimidated. You notice you have high blood pressure. Your blood pressure goes up when you see a white coat. Many individuals do that. We see patients in the clinic, they're 190 over 90, and they take it later after they've calmed down and the blood pressure goes down. So there's a lot of anxiety around the healthcare system. They don't know a lot about the different diseases, and they've not done any research, for instance. One thing I'd like to point out is that you are responsible for your health care. You know your body better than anyone else. And you need to go into your doctor's office for wellness checks. Go into your primary care physician. He's the spoke, she's the spoke of the wheel. So make sure that you go in there and you're prepared. You have your questions, you have your symptoms, and you have power.
Do you think that most of the time, well, We did a study of 600 African Americans, and they asked them where they expected to get their health information. The national survey we finished last year. And all this internet, they expect to get it from the physician. But the physician barely has time to tell you what's wrong with you today, much less to try to integrate into your information system things about early detection, disease prevention, and even some of the other things. How important is communication as regards to the action plan as you're about to leave the doctors, particularly in relationship to the medication?
Well, we say, and look, we reiterate this several times, you don't leave the office until you have repeated what the doctor has told you. You repeat it once, you repeat it twice, you repeat it 3 times. From the diagnosis, from the medical decision-making, which is very critical. Well, why are you doing this? That's what the doctor needs to focus in on. And there are components of Medicare reimbursement now where you have to have medical decision-making. You can't just come into the office and look at a chart and say, well, I want you to take this, this, and this, decrease this, change this. You have to have a discourse with that individual to let them know what is your decision-making with this, and you should demand it.
I think that's particularly important now because most doctors can't type.
Right.
And I went to see my doctor the last time. We spent 90% of the time trying to type 3 or 4 sentences and didn't even get to the things that I was concerned about because of the medical record, and he was challenged. So it's particularly important that you be organized. Dr. Newell, Gladys Knight had this, well, I think it was Gladys Knight before Barbara Streisand, but maybe she was first that said, was it all so simple then, or is time rewritten every line? Do you think people remember what the healthcare system was like before the Affordable Care Act? And what are the new challenges that we're facing now?
You know, I think that some do. Some do remember what the healthcare system was like before, but I think it was all a very passive situation where you go to the doctor, you trusted everything the doctor said, you asked no questions. If he or she said take this medication, you took it, and there were no questions asked about it. If you had a problem with it, which is what I have heard sometimes from my own husband, well, the doctor gave it to me. I'm like, but you're not supposed to be taking that. But you have to really, now we have, I think, a shift, which is, why do I have to take this, period? Can't I just take garlic from my blood pressure? Why do I have to take, and do I have to take this for the rest of my life? I've actually even had patients that have said, oh, I stopped taking my blood pressure medicine because the last time I was in the office, you said it was good. So there's a lot going on in terms of communication. People are reading. It's funny that you said that your research said that patients were getting their information from the doctor. That's very interesting.
That's where they
want to get it.
Oh, they wanted to get it.
Expected to get it.
Okay, very good. Because I find most people get it from the internet. My own child will go to the internet before she'll come to me. And then she questions, you know, oh, well, the internet said. So I think now we're dealing with the internet. The internet is a primary place for people to get their health information. And so so there's good and bad in that. Because I think the good part about it is they're coming in with knowledge. And then they're really questioning you as a physician to really make sure that you're on your A game. Patients will often come in and say, well, what do you know about this medication? I saw it on television. So you have to be very honest about, you know, whether you know it or not. But I do think, to answer your question, I do think healthcare has changed. I think the internet has helped to change it. I think that some of the requirements of the Affordable Care Act and the healthcare plans are really empowering patients to be able to have an opportunity to speak up and speak out more for the things that they can read their charts now, you know. Used to be we kept all that stuff private. But now you're entitled to all your own records. And if we give you your records, we have an obligation that we need to sit with you and explain to you what's written in the chart. Because if you took a chart and read all the stuff that we wrote, it might not be a good situation.
23% of the health sites on the internet are trusted sources. That means that 67% are not. And so there's a lot of misinformation that comes out of the internet as well. So, and there's a big digital divide in terms of who uses the internet. It's a digital divide in terms of age, where the sickest people are, they don't use it as much. And then by race, because African Americans, you know, I do Instagram and the other things, but to intelligently search for explanations, I think, makes it very difficult. But
I I'd like to go back to the exiting the doctor's office, because you need a plan. And I know with the other challenges that we have, doctors have with the electronic health records, that's the other new challenge, because it's a steep learning curve for a lot of physicians, especially those who've been in practice for 20 to 30 years. But when you exit the doctor's office, besides repeating what I just said as far as the diagnosis, the medical decision-making, your medications, how you're to take it, what the dosing schedule is, you should be given a form, a sheet, with all of that information on it, so that you can review it with your advocate, with your spouse, with your child, to review with you. Because many times you go into the doctor's office, you hear things and it goes straight over your head, especially if you go in with something serious. You don't hear anything. If you think you have a serious problem, take someone with you.
What are some of the new challenges? Since you wrote the book about 3 years ago, what have been some of the new challenges that people face? One of the things that I find is that people, when they have private insurance, they think that's a ticket to ride. They don't know what their benefits are, they don't know what their deductibles are. But what are some of these, with the change in the healthcare landscape, tempered by the Affordable Care Act, what are some of the new challenges that you see people facing where advocacy is even more critical?
Well, I'll tell you one thing, and this goes with individuals who get their insurance from their employers, and they're given choices of what health plan to use. And these are people who earn a significant amount of money, and they don't think that they really require the healthcare system all the time. So they have high deductible, they have medical health savings accounts, and they don't go in for wellness. They don't go in because they don't want to pay the deductible. So then you have a buildup of disease and issues that they'll have when they finally hit the wall, and then they'll go in. So that's one of the main things as far as private health care.
Dr. Newell?
I think really truly understanding what you're buying. I have found that with my company, you basically are told to go log in, read about it yourself, and figure out which plan you think works for you. And people don't really, and if you happen to be in a relationship where you have a partner or a spouse that also has insurance, it's something you need to really understand what that spouse's insurance is as well, because you can be over-insured and really not benefit from it. And so a lot of people think, well, I'm going to get the most expensive insurance and that's really going to be what's going to help me. And it's really not the case. So I also have to say that with all of the options that are now being given, you didn't have so many before, but with all the options that are now being given to individuals, because there's so much about patient rights and what patients need to have, I just don't think that, and I think I have to blame the companies for it. That if the companies are going to give you the insurance, and the company should have some requirement to bring in some educators. My company has not educated anybody in our company about anything that has to do with any insurance. And as a physician, I get on the telephone with the folks every year and spend at least half an hour trying to figure out whatever the plan is that I'm trying to look at. So I think that's one of the things. I think the other thing that I think is a little new is that I think there's a little bit more education now about power of attorney and what's the other term I'm thinking of? End of life care. End of life care. I think there's more of that, and that was something that we did not address in this book. The notion of end of life care. I think that's something that we talked about it, but I think that if there really ever was a place where you really need advocacy, it's at end of life care. Not only does the loved one need it, but the rest of the family needs it. And one of the things that I know that we have talked about as physicians is the concept of kind of having a spokesperson for the family. It's very challenging in a situation where you have a loved one that's ill and you've got, all the, grandma and cousin Tukey and Mary and Johnny and Susie, they all descend on grandma's room when she's finally really sick. Now, many reasons why that depends on how much life insurance she has, but they all descend and then they all want to talk to the doctor because they've all flown in from Louisiana, Mississippi, Alabama, and Oakland and Fresno, wherever. And but it's really important in terms of the care of the patient. That's another advocacy piece, that you really try to identify the primary spokesperson for the family, so that because that advocate needs to also help prepare the family for what's going on, because a lot of times you're feeling like they're taking away. Why doesn't grandma have her this or that anymore? Or why don't they have this? Or I used to see this there and it's no longer there. So that's another aspect, I think, of advocacy that probably deserves its own chapter. That we did not address.
Yeah, nothing breaks up families more than marriages and funerals. And so we have, all of us who have dealt with this problem have seen this become such an bizarre issue.
You know, during the election when the Anna Gray woman from Alaska was running for vice president, Sarah Palin, do you remember how she twisted the thing about end-of-life care and talked about it being something evil, and that you were talking about doctors killing people and stuff? I mean, because that's another thing that happens in political discourses. People use things, and she affected a lot of people by demonizing the idea of end-of-life care.
Right. And those of you who are either have children or grandchildren or siblings, you need to get this straight way before something happens to your parents or grandparents, because some brother will show up from Chicago and looking around at the assets, and we've all seen that happen. Ms. Brown, you brought up a point about advocacy and caregivers. Every study I've ever seen in chronic disease suggests that if you have advocates, that you are trained advocates in any chronic disease, you can increase decrease the morbidity and mortality, and patients have a better quality of life, except nobody pays for it. I mean, it's been study after study. So I'd like to ask Dr. Newell, who makes a good advocate, knowing that even though we've shown that patient care advocates change dynamics, who makes a good advocate in the absence of that?
Well, I think we want everybody to leave this seminar today understanding that each and every one of you can be an advocate. So of course, there are different levels of advocacy. And of course, Dr. LeNoir and Dr. Spriggs and I are at a certain level of advocacy just based on our training. But I think it's important for all of you to understand that every single one of you can be an advocate. We talk about something called peer advocacy, and that's your family member can be that. If I've said before, if every time you take grandma to the emergency room, grandma gets an IV bottle that runs in over 2 hours, and if all of a sudden you bring grandma to the emergency room and they run that IV bottle over 15 minutes, you ought to just ask the question, what's in the IV bottle? In my own situation that happened with my family member, instead of the IV going in at 150 or 200 cc's an hour, they forgot. They left the line wide open, and my mother got 500 cc's an hour over about 2 hours. And so, you know, I'm like, okay, well, are you gonna be here to watch her go into congestive heart failure, or will I? So you just need to pay attention. So there's something called peer advocacy. So there's peer, you can be it, or you can have a nurse friend. If you have a nurse friend, an LVN friend, or an RN friend, they can be an advocate for you. But I think, as was pointed out by Congresswoman Barbara Lee, take somebody with you. Just take, if you've got a living body that's breathing, that can walk and talk and pay attention, that is the person that can ask the question. When you're in pain in the emergency room, you're often not thinking about who was in here last and what they put in your arm. You're just not focusing on that. But you need to get shifts. I told this to people. I've said to some of my church members, if I need to do the midnight to 4, call me. But don't leave your loved one in the hospital overnight without being at the bedside. I've seen so many people say, oh, it's not, my husband was in the hospital recently, and family members came, and family members were leaving, and I said, okay, I'll see you. And I remember one family member said, you're not going home? I said, no, indeed. There is no way I am leaving him in this hospital overnight by himself. I don't care how many nurses are here. The stuff goes down at night. That's when the stuff goes down. Your staffing is decreased. Your loved one is asleep. And I have to say, every single time I have been at the bedside of any loved one, I have awakened at 2 in the morning with stuff going down in the room. Every single time. Who wakes me up at 2? The Lord, I think. But every single time it happens.
And we always say, you know, pray with me, but stay with me.
We talk about this in the book also. Every time there's a handoff, we talk about handoffs in the book. A shift handoff, a day handoff, going to a skilled nursing facility, any of those events that happen, stuff will fall through the cracks. So that's when you really need to be there, and you need to know what the transfer means to the patient, who's going to monitor that, who's going to make rounds for that individual, and what facility you're going to, what are the services that are afforded there for the individual. So that's also a part of caregiving. But I want to go back to your thing about communication with the family. And some years ago, one of the leading journalists wrote about the conversation. And that's what you need to start addressing. What is the conversation? The conversation is the wants and needs of the individual. And you need to get it recorded, get it written down, so that there's not chaos when everything happens and goes south.
Since we know that there's not going to be too many caregivers, what are some of the things that a good advocate actually does? The structural things, Dr.
Well, you could do anything from, it depends on the level again, like Dr. Newell mentioned, there are different levels of advocacy. But the thing is to be a set of ears, another set of ears. You can research if you're able to do that, what the patient has. You can take notes, you can use your power to request a second opinion for the individual. That's your power, and that's your right to ask for a second or a third opinion. And to stay alert during the visits, be able to interpret to the patient that you're advocating for what that person's responsibility is also for that health care or the management of that health care. And if all else fails, get a certified advocate.
Yeah, in the African American Wellness Project, we were trying to decide how we could have the most impact. And although I was voted down, as I usually am with these ideas, I thought if we just got a button with an eye on it saying we're watching you. So if anybody went to the emergency room, we all belong to our group, and it's the AAWP, an eye on it, and we're watching you. And I think that would make, because don't ever underestimate the impact of racism in these decisions. And how you treat it from the desk all the way through to the person taking you back out to the car. Because I saw a study recently that talked to a group of doctors in New York, and they said they all had already preconceived notions about black people from their medical school thing, but it didn't affect their decision making. I said, please. I wrote a letter to the editor and said, please, how could you as a scientific journal even print this? But don't ever underestimate the importance of racism. And when you go into the hospital, it may even come from a ward clerk, or it may come from somebody doing an X-ray. And don't hesitate to call it what it is when you see it.
It may come from another black person.
And absolutely.
Yeah.
Well, we know that inherent bias and implicit bias, those are the roots of healthcare disparities.
Yeah.
That's why we have healthcare disparities. And so you have to, and all of us have our own prejudices, our own issues with certain individuals, but as a physician, you have to block all of that out and make sure that it's the patient's welfare that is primary.
Does everybody here understand the difference between health disparities and healthcare disparities? How many people understand that difference?
Can you break it out?
The health disparities are what happens to you because you are in a certain ethnic group or a certain genetic cluster. Like we have more intrinsic hypertension. Healthcare disparities have to do with how you're treated when you enter the healthcare system. If you look at the statistics, we are the only ethnic group where socioeconomic status, employment, and education has less impact on our health than any other ethnic group. By that I mean, if you're Latino or Caucasian and you have a college degree and a good title and all that, then your health levels go up for almost every disease. That's not so true for African Americans. The study on maternal mortality is the classic example of what happens, because in those studies where black women die, 3 or 4 women that die are African American, in those studies, most of those deaths are preventable. When they go back and look at them, these are preventable deaths. And they always say the same thing, well, it's access and poverty, and then they throw in, and they don't believe in health. Because of the Tuskegee study, they don't trust the healthcare system. Nonsense. Everybody wants to live. So that's nonsense. So don't underestimate the importance of racism.